Very good morning, and it is a great honor to present in this forum, especially in front of the esteemed panelists and the chairpersons. Today I'm going to show you the journey of three women who came with a VT. The first case is in the 2016, 55-year-old woman who came with a typical chest pain and a palpitation, whose pulse is 190 beats per minute and has a feature of heart failure and hemodynamic unstable. This was the ECG showing there is a narrow complex regular tachycardia. During that time, it was a diagnosis of the non-STMI with SVT, and the echo shows severely LV dysfunction with the RV dysfunction. CAG showed mild CAD. Now 2021, patient came again with a palpitation. This time around, white complex regular tachycardia, we can see there is a presence of AV dissociation. So we diagnosed as a case of ventricular tachycardia. There's a RBB morphology with a superior axis. The echo shows the LVEF around 50%, but there's a hugely dilated RV with the RV thrombus. After giving the amiodarone, transiently it is reverted back to the sinus rhythm. If we magnify that, we can see there is a no seen just after the QRS complex. So this was the epsilon wave. But unfortunately, few hours later, VT started again. But we tried every drugs, but didn't revert it back to the sinus rhythm. And 2 weeks later, it becomes sinusoidal in pattern. But unfortunately, 3 weeks later, patient died. And we diagnosed as a case of ARVD. The management should have been to categorize this patient to the higher risk group, put an AICD, give the antiarrhythmic drug, preferably beta blocker or sotalol, anticoagulation for the thrombus, and anti-failure drug. The second case is 32-year-old woman who came with a recurrent and drug-resistant SVT. Pulse was 232 beats per minute. This shows the narrow complex regular tachycardia and diagnosed initially as the SVT. Medical guided therapy was given. Ultimately, DC cardioversion was done, but it also failed. Half an hour later, patient went into the cardiac arrest. After returning back to from the cardiac arrest, we put her onto the mechanical ventilator. Then, half an hour later, we decided if we see that it is attentively, we can see there is the AV dissociation. So we decided for the emergency EP. This was a race against time, so there's the AV dissociation, so this is a VT. Echo and CAG shows normal, so it is idiopathic in origin. RBB morphology so came from the left ventricle. It is a narrow QRS complex, so this is a fascicular origin. And there is a right axis deviation, so it came from the anterior fascicle. After doing the EP followed by the radiofrequency ablation, it reverted back to the sinus rhythm. Here we can see there is a beautiful memory sign also. So for this ILVT, the curative management is RFA. This one is the last case. 65-year-old woman who came with a palpitation for 1 day and the GIT symptom for 3 days. She is a post-CABG atrial fibrillation and got digoxin for this for 3 months. Came with a pulse 150 beats per minute and the hemodynamic stable condition. This was the ECG showing the white complex regular tachycardia, but interestingly enough, there's a rhythm strip shows the beat-to-beat alteration of the QRS complex. So we diagnosed this case as a bidirectional VT, and digoxin level was 8.7, so that we give the injection lidocaine. After giving the lidocaine, it became reverted back to the sinus rhythm. For this patient, bidirectional VT, the first line choice is the anti-digoxin antibodies. If it is unavailable, then we can give magnesium, lidocaine, phenytoin. If unstable, DC shock. Amiodarone if the other drug failed, but very cautiously. So the take-home message is, this is a journey of three women with a three etiology, 3 types of VT, and 3 ways of management. ECG is the first tool of the diagnosis of the case of VT, and it also gives the clue of the underlying cause. Different type of VA requires individualized management. Sometimes antiarrhythmic drug can act as a double-edged sword. Multidisciplinary setup is essential in case of any complication arises. Thank you all, and thank you all for your patient sharing.